Hello and a very warm welcome to everyone joining us for today's webinar, which is titled Rising to the Challenge, Diagnosing, Treating and Managing Respiratory Infections Using Rapid PCR Testing at the Point of Need. My name is Ellen Sims and I'll be moderating today's session, and I'm delighted to introduce today's panel of expert speakers. We have Jonathan O'Halloran, who's the CEO of Quantum DX, Professor Curtin Dida, who's the Professor of Respiratory Medicine at the University of Cape Town, Dr. Jordi Vila, who's the Head of Department of Clinical Microbiology at the Hospital Clinic, Barcelona, Spain, and also Professor Sanjeev Krishna, who's a Professor of Molecular Parasitology and Medicine at St George's University of London. In this session, understand the importance of rapid PCR respiratory infection testing at the point of need, and discover a new rapid PCR respiratory testing solution as we look to the future of respiratory disease management. Following on from this presentation, we will have a question and answer session. So if you have any questions for our speakers, please feel free to submit these at any time during the webinar. So without further delay, I'll hand over to our speakers for today's presentation, and I'll thank them for presenting to us today. Please go ahead.
Good day, everyone. It is a real pleasure today to be able to set the scene for why we need PCR multiplex respiratory testing. And before I do, I just wanted to introduce myself. I'm Sanjeev Krishna. I'm a professor of molecular parasitology and medicine at St George's University of London. And I'm also an infectious disease physician. I'm affiliated with a variety of international organizations, including the University of Tübingen, through which we have a network that extends to many different clinical research sites throughout the world. Now, it's conventional before beginning a presentation for speakers, including myself, of course, to mention any interests, and I am a consultant to Quantum DX. I'm also a shareholder, and I do consult for other diagnostics companies as well. One of them is listed there, and many of my consultations, of course, will be informal, not just formal consultations. To come back to the question of the webinar today, why do we need PCR respiratory testing? Well, in the COVID, and let's hope eventually post-COVID era, I think if you put this question to a member of the lay public, the answer now would be because I need the freedom to be able to do what I want to do, whether it's to visit vulnerable relatives safely, whether it's to travel, whether it's to be able to get back into work as quickly as possible. I think these are the sorts of questions these are the sorts of answers that would arise from this question. And I think it also shows very clearly how the COVID-19 pandemic has changed and educated thinking amongst the populations now who've had this pandemic afflicting us for more than 2 years. Now, when it comes to the medical basis for why we need testing, I think there are some key points that have emerged when it comes to respiratory pathogens. The first is that clinically, the spectrum of infection varies enormously. It can be from symptom-free all the way through to really severe and unfortunately sometimes fatal infections. And the where we end up on the spectrum really is unpredictable and will vary depending on the viral pathogen that's involved, as well as perhaps the viral variants within a particular pathogen type. Now, an additional feature is that if you take the 3 pathogen groups that we're looking at, whether it's SARS-CoV-2, flu A, B, or RSV, RSV is mainly, not exclusively, but mainly a disease of children. So most of the discussion will focus on the commoner um, infections caused by SARS-CoV-2 and flu A B. Now, when you look a little bit more closely at the clinical spectrum of um, symptoms and signs caused by these pathogens, the range is very wide. You can have non-specific symptoms, which everyone is familiar with, whether it's headache, muscle aches, fevers, and so on. And then you end up with some features which vary in their frequency and come and go, whether it's loss of sense of smell or taste. And then you have more features as well that can sometimes emerge, whether it's GI symptoms or other localizing features. So the message here is clinically, it's very hard to distinguish a cause, a specific viral cause associated with a particular symptom complex. And the whole mixture becomes even more complicated when you take into account that some people will have had, and I hope for most people now for SARS-CoV-2, vulnerable populations for flu. Some people will have had immunizations, which will also modify the clinical presentations if they develop clinical features of the disease. And other aspects of infection also that we always take into account are what are other risk factors that can make symptoms and signs worse in particular individuals, so-called comorbidities. So the whole thing is quite complicated when it comes to clinical assessments. Why do we need, particularly, other than confirming a diagnosis, why do we need particularly to test for these respiratory pathogens? Well, fortunately, one of the key answers to this question is that if we diagnose an infection caused by some of these pathogens early enough, we can then initiate effective treatments. And so access to the appropriate treatment options really is predicated on confirming a diagnosis. Now, if the options to diagnose effectively at point of care are not available, then really one is left on the one falls back on the epidemiology of the infection. So if there is an outbreak of flu, or if there is an outbreak or an increase in the frequency of SARS-CoV-2 infections, then you might be forced, if you like, to treat empirically on the basis of symptoms. But as I've just highlighted, the symptoms vary, the spectrum of disease varies. It's very hard to distinguish one cause from another. And yet, the treatments are quite different for syndromes caused by flu viruses compared to the treatments that we use for SARS-CoV-2. And I've listed some of them there. You have inhaled or orally available, or even intravenous treatments actually available for flu. And you have a variety of treatments that have really been discovered and developed extremely quickly for SARS-CoV-2 infections. For RSV, it's still very important to understand this cause of infections, because it has implications as to how you manage patients in terms of where you put children who have the infection, in terms of which wards you put them on, what sort of isolation measures you adopt, and so on. So, if patients have symptoms, it's very important to confirm the cause of these symptoms early, because it influences what treatment options are available for the patient. But it also goes further, as I've hinted with the RSV infections in children. A diagnosis really also influences how patient flow is managed. So that, for example, when a patient comes to hospital, it becomes very important to recognize whether the patient needs to be isolated or if patient numbers increase to be cohorted, which means you put patients with the same kind of infection together in wards and isolate wards from other places in the hospital so that, apart from anything else, so that the rest of the hospital can function to deal with the huge pressures that the NHS is facing at the moment. And the same points would apply if symptomatic individuals were diagnosed in the community, because the advice you would give those individuals would take into account exactly what we're discussing now: isolation procedures and appropriate treatments. Now, if you look at where early diagnosis is important. Of course, it's also important at point of presentation when patients are deteriorating and need to be admitted to hospital and are being seen by let's say the healthcare workers who are attending them in the community. And if you can make a diagnosis early at that stage and confirm the diagnosis, that has an immediate impact as to how patient flow is managed in terms of where they get taken and how they get managed in the hospital. And similar comments also apply, of course, to children who may have RSV. Now, I've mentioned where early testing confirms treatment options and management plans. Of course, there are situations where you have the need for asymptomatic testing. So this is where patients may not have any symptoms. Maybe it's too early in the course of infection. The infection is still there, but it hasn't declared itself clinically. Or the infection itself in that individual may never progress to cause symptoms, certainly for SARS-CoV-2. And here, of course, it's very important to detect infections early when you have the potential for exposure in at-risk individuals. So this could be vulnerable populations in care homes. We all know the stories in the early phases of the SARS-CoV-2 pandemic. Travelers, of course, who need to be sure that they're not going to be carrying infection if they go to a different country, high-risk individuals who are immunosuppressed, key workers, including healthcare workers, of course, pre-surgery, and GPs, surgeries, and pharmacies, where now the testing in asymptomatic individuals can reach more widely in communities. Who, let's say, if somebody wants to confirm that they don't have an infection before visiting vulnerable parents, for example. Now, one area where both it could be related to either symptomatic or asymptomatic testing, but one area where it would be particularly important to have a rapid result would be, for example, in accident and emergency contexts in departments, in A&E departments. Because here you've got a high pressure of individuals coming through with a variety of different conditions, and the risk of transmission is very high. So the sooner you can free up a side room where you're putting a patient who may or may not be transmitting one of these infections, the sooner you can either confirm the diagnosis and put them into the appropriate patient flow, or exclude the risk of infection using a multiplex highly sensitive technology for diagnosis, the better it is for managing the pressures in the NHS. Let's have a look quickly in the last slide or two as to what the recommendations are. For example, in the United States, here are some clinical practice guidelines looking at the management of flu. And of course, the same comments could apply to SARS-CoV-2 or RSV. What is clear is that the best assays which are clearly, in terms of accuracy, the assays that use RT-PCR approaches, molecular assays. The best assays are the ones that ought to be used to exclude or include the presence of these very common respiratory infections. And multiplex testing is encouraged. And it comes back again to the issue of being able to apply treatments and management as soon as possible. So, to summarize, multiplex point of care testing really is critical in confirming the cause of common viral respiratory pathogens. Um, the epidemiology of these pathogens is changing because of our changes in behavior and immunizations and so on. And so it's very important to confirm with molecular tools. The confirmation allows for early interventions, which include specific treatments and implementation of patient flow and management. The RT-PCR approaches, multiplex approaches, maintain accuracy. So really, they bring lab quality testing to rapid near patient results. And clearly, one of the key benefits of doing these testings is to reduce transmission in the communities by interrupting chains of transmission, and they allow more widespread collection of data, epidemiological type studies, mapping of outbreaks, and so on also. So I hope that I've set the scene now for you for this, for thinking about multiplex point of care testing for respiratory pathogens. Thank you.
So it's for me a pleasure to show you the results of about the evaluation of the quantum QPOC, which is an assay to detect SARS-CoV-2, flu A and B, and also RSV. This is for the rapid diagnosis of respiratory infections. These are my conflicts of interest to report. And when you think about what are the main characteristics of an optimal microbiological diagnostic test, of course, the first the most important characteristic is a high sensitivity and specificity. In addition, we need rapid tests. This is important mainly when we are having patients in the emergency department and we want a rapid test. So if the test can be fast in minutes, better than in hours, this is another important characteristic of this optimal diagnostic test. The third is the ability to process a large number of samples. This is relatively important. I mean, it's if you have to a lot of samples to process, that's important, but it's not really that's not really matter. The system has to be automatized. I mean, if the assay is automatable, that's perfect. An integrated system where you put the sample and after few minutes or an hour you get the result, that's perfect, because that doesn't take so much time of the technician in order to prepare the sample and to run all the different steps in the PCR. And finally is the cost-effective analysis is also important to perform for both the reagents and the equipment. And of course, our administrators in the hospitals will be happy if the cost of the assay is affordable. It's important, the sample collection. That's crucial. Sorry, that's crucial to have a good sample in order to get a good result when we apply the assay. That has been very important during the COVID-19 pandemic. Several samples can be collected when we are talking about respiratory tract infections, either upper samples such as oropharyngeal swab, nasopharyngeal swab, sputum or induced sputum. And when we suspect a pneumonia, it's much better to collect lower respiratory tract samples, such as bronchospirate lavage or endotracheal aspirate. And normally during the COVID pandemic, we used to collect two swabs, one from the oropharyngeal area and the other one from the nasopharyngeal area. How have we prepared for winter viruses? Exactly, we don't know what will be the behavior of the main current respiratory viruses. taking into consideration SARS-CoV-2, flu, and RSV in the next autumn winter. So we don't know if all of them will be the same circulating at the same level, more or less. One of them will be more predominant than the other one, so that we have to wait until autumn or winter in order to know exactly the situation. No? But we have established a double action strategy to detect these viruses. The first one is the use of rapid testing for SARS-CoV-2 together with flu A and flu B and RSV. And of course, if all of them are circulating, that is the perfect site to perform. However, we will adapt according to the scenarios I mentioned. We will use a rapid diagnosis with a result in less than 1 hour, of course, with an integrated platform to carry out the RT-PCR. And this first approach will allow us to proceed to process those samples that arrive mainly from the emergency room. We have in our hospital a vacuum tube connecting the emergency department with the clinical microbiology laboratory, so the sample can be collected in the emergency department and in less than 10 seconds arrive to the clinical microbiology laboratory, and then we can run the sample right away. The next strategy is when we have a lot of samples and we want also to perform the screening to detect SARS-CoV-2, flu A and B, and RSV, and probably other respiratory viruses. So we want to perform a high throughput screening. We're using a modular platform, and we get the result normally around 6 hours. So it's different. It's not considered, cannot be considered, of course, a rapid test. When we performed the evaluation of the quantum QPOC for SARS-CoV-2, flu A and B, and RSV, so the aim was to compare this assay with a comparator. The standard diagnostic comparator was MOSFOR, which is a panel also detecting SARS-CoV-2, flu A and B, and RSV. What we did was to samples that arrived to the hospital and that we screened it for SARS-CoV-2 with the COVAS platform, and with the flu A and flu B and RSV with two different platforms, the LIAT and the FLOW platform. From those samples, we selected 110 samples that were processed in parallel in both in the QPOC and also in with the standard comparator, the MOSFOR. This is the results that we got. The sensitivity for our SARS-CoV-2 was 98.7. We had 78 positive samples that coincide with both assays. For flu A, the sensitivity was 100, although we have to say that we only had 5 positive samples for flu A. For flu B, we didn't have any positive, so we have to wait to collect more samples. And for RSV, the sensitivity was also 100%, although we need to extend the study in order to incorporate in the collection more positive strains, mainly for flu B and RSV. When we analyze what we have experienced, the different rapid integrated systems that there are in the market, these are the ones that we are familiarized with. They are not the only ones that are in the market. In the market, there are more. But I would like to compare the characteristics of the QPOC with the other ones in the market. For instance, QIAstat, diagnostic, and film array are syndromic assays. That means that in addition of detecting SARS-CoV-2, flu A and B, and RSV, it can detect other respiratory viruses. It takes 1 hour. And it's important to consider if the platform provides you information about the CT, and also if the platform is giving you the availability to see the kinetics. For us, to see the kinetics of amplification is really very important, because some kind of positive results, mostly when the CT is a very high CT, we want to see the kinetics, because sometimes it's an aberrant kinetic that is not really a nice kinetic amplification, and that considered this as a negative result in this case. So we see we want to see this kinetic of amplification. And I said, FilmRI did not provide to you this kinetic of amplification. For other platforms, for instance, Simplexa has two panels, one including VRS and flu, and another one for SARS-CoV-2. It takes 1.5 hours. It provides you the CT, but also you can see the kinetics of amplification. For Expert Express, the panel is a four-plex panel, including SARS-CoV-2, flu A and V, and RSV. It takes 35 minutes in getting or in obtaining the result. You can see the CT, and also you can see also the kinetic of amplification. With LIAT, the assay doesn't include RSV. Is only for SARS-CoV-2 and flu A and V. Takes 20 minutes. You can see the CT, but you cannot see the kinetics of amplification. And finally, for the QPOC, the turnaround time is 35 minutes. As I said, includes SARS-CoV-2, flu A and B, and RSV. You can see the CT, and also you can see the kinetic of amplification. So the take-home messages that I would like to give you from my talk are, first of all, rapid all-in-one testing allows differential diagnosis of respiratory infection for the most prevalent respiratory viruses, such as SARS-CoV-2, flu A and B, and VRS. PCR, as you know, is the most often used tool to detect respiratory viruses. And as I mentioned, we have two scenarios when we have just a few samples or only one sample, or you really need a rapid result, that you can use an integrated system with a turnaround time less than 1 hour. And then the other scenarios, when you have a lot of samples, you want to do a high throughput screening, and then you use a platform that can process a high number of samples and provide you the results in around 5-6 hours. The analysis of the limit of detection of QPOC for the different viruses has also already been determined. For SARS-CoV-2 is 250 copies by mail. For flu A is 1,000 copies by mail. For flu B, 250, and for RSV A, 4,000, and for RSV B, 1,500. And it's important to mention that QPOC meets most of the characteristics that we mentioned in the beginning of my talk: good sensitivity and specificity, a turnaround time of 35 minutes, and is an integrated symposium. And that's all. So I would like to finalize my talks thanking the people from my lab working hard during the pandemic of COVID-19, both the technicians and the medical staff. And this is the human tower, typical from Catalonia, which is representing the effort of a group of people to obtain an aim, to obtain the main objective. And that's all. Thank you very much for your attention.
Thank you for that kind introduction, and thank you kindly for the invitation and the opportunity to present our data from the University of Cape Town and the University of Cape Town Lung Institute. So just to give you a brief overview, I'll first talk about some clinical and public health considerations to bear in mind with acute respiratory tract infections, then present the objective and outcomes of the study, including the results, and then say a few words about our experience in terms of likability and user friendliness of this assay. So as all of you would already know, COVID-19 has now become the foremost infectious disease killer globally over the last few years, and the death toll continues to rise and is well over 6 million now. Symptoms of this disease are acute and non-specific, and thus the differential diagnosis in ambulatory and hospitalized patients is quite wide. As you know, respiratory infections do not read textbooks, and what you are confronted with is a patient with respiratory symptoms, and they may have one of a number of different infections: COVID-19, influenza, respiratory syncytial virus, bacterial infections, and even acute tuberculosis in our setting. Now, it's imperative that we minimize the use of antibiotics, as you are also well aware, given the increasing rates of antimicrobial resistance. However, in order to achieve this, accurate diagnostic tools are essential. not only to direct treatment, but also for several public health considerations and interventions, including isolating individuals either in congregate settings or in hospitals and so forth, and also, as I already mentioned, to minimize antibiotic usage. Treatment options do exist for some of these infections, but are quite different. And depending on the therapeutic intervention, this could only be appropriately executed with an accurate diagnosis. So, for example, we do use oseltamivir for influenza and Paxlovid in clinical practice. Again, another reason why you need quick, rapid diagnosis. So, why QPOC? This assay is user-friendly, has a rapid turnaround time, and requires minimal scientific experience. This is a very important point in our setting. There is a dearth of qualified laboratory scientists and personnel, and we often have to get non-professional laboratory staff to run assays, and such staff can easily be trained. The other important advantage is the turnaround time. The assay results are available within 35 minutes at point of care, which makes it very convenient. The portability of the device enables active case finding in congregate settings. For example, airports, schools, concerts, events, and so forth. And another very important consideration is that the battery life allows up to 5 tests to be consecutively run. So battery life in the region of about 3 hours. And this is very important in the event of power interruptions wherever you might be. The assay encompasses high quality multiplex PCR testing with simplicity and speed close to that of a lateral flow assay, and empowers healthcare professionals to treat rapidly and effectively. So the objective of the study that we performed, and this is an ongoing study, and I will show you the preliminary data, was to evaluate the diagnostic performance of the QPOC assay compared to a multiplex CE-IVD marked standardized assay that we acquired. I'll take you through the details. And this was a prospective cross-sectional study, and we collected samples and data from participants with acute respiratory infection within 4 days of symptom onset. So moving on to the results, here you can see the demographic characteristics in about 40 participants. As I said, the study is ongoing, and here I show you the analysis of the first 40 participants just to highlight a few things. In the table, the median age of 32 years, you can see the breakdown of symptoms, pretty characteristic of individuals presenting with acute respiratory infections, and symptom duration. You can see median duration of symptoms prior to testing was approximately 3 days, and about 25% of the participants had various comorbidities, and you can see the breakdown in the table. So moving on to what we found thus far, this table encompasses the performance outcomes, sensitivity and specificity, and predictive values. We had a total of 40 participants. Of those, we had 9 individuals that tested positive by the reference assay, and I'll show you that on the next slide, giving a sensitivity of 100% and a specificity of 100%. With obviously very high positive and negative predictive values, and likelihood ratios in this case we could not calculate because of the 100% values. Here's a breakdown showing some details of the reference assay we use, which was the BOS4 assay, and this amplifies 3 genes of interest. There's an internal positive control, and here you can see the QPOC results and symptoms of individual participants and the symptom duration prior to testing. So what were our impressions of this assay when we evaluated it? Well, firstly, overall, we thought this was a very good platform. It was easy to operate, intuitive, and with a small spatial footprint. It doesn't take up a lot of space. It's an important consideration if you're testing in congregate settings. And the other thing is to bear in mind is that the assay is modular in design. So you can use a number of assays in parallel, depending on the throughput you wish to generate. One thing we found was that the pasture pipettes could potentially replace the current volume lock pipettes might make it a little bit easier for non-LAMP trained persons, but I believe that's something that's being looked into. The sample preparation and test runtime was considerably shorter than the standard singleplex assays we've used before and the multiplex PCR system, in this case, even the reference system that I showed you. A qualitative test result is easy to read from the digital display. And in summary and conclusion, the ease of operation, rapid simple preparation and application, and easy to read results, in our view, empowers healthcare professionals to provide a molecular diagnostic outcome at point of care. And in particular, a major advantage of this system is congregate settings and workplaces such as airports, concerts, schools, and other locations. So to end off, I want to acknowledge Quantum DX for its fabulous R&D and the product that they have put together that we feel would definitely be an advantage in the fight against COVID-19. Major advantage being the rapid test format and ability to diagnose alternative respiratory tract infections. In this case, it's early in the early phase of the study, and we didn't really see individuals yet, given the small number. But we are seeing RSV and influenza infections now in South Africa, and so look forward to sharing the larger data set with you in the future. And this is just to acknowledge members of the team at the Center for Infection and Immunity at the UCT Lung Institute and the University of Cape Town, and also some of the scientists who were involved in this evaluation. So I thank you for your attention, and we'll be happy to take any questions in a short while. Thank you.
So thank you very much to Sanji, to Geordie, and to Kearton for their wonderful talks. I thought what I would do in my portion is to explain the technology a little bit more, how we're positioning it, and then talk about why we've come up with a respiratory panel test at this time. So as you can see in front of you, this is our QPOC device. It is a very small, rapid PCR testing device that is positioned at the point of need. As you can see, it is perfectly proportioned in the sense that you can put this on an empty space on your lab bench quite easily and stack several of them together on the top of each other. And you can easily get access to the screen and the front-loading mechanism. It is portable, of course. We have a battery on board, and so this is really so that you can take it to the patient, to the true point of need. We hear about point of care quite a lot, but generally what that is meaning at the moment in the industry is stat testing, whereas we're really providing something that you can take to the patient side and run the testing there, which is really important. And a part of this, of course, it's very lightweight. I regularly take QPOCs to conferences and meetings in my backpack and never have a problem carrying it around all day. And with it being battery operated, I can run tests anywhere I wish. And finally, the QPOC comes with all the connectivity that you would expect from a modern day device. It has the Ethernet connection, USB, the cellular connections, Wi-Fi and Bluetooth as well. But this is the device that runs the cassette, and it's really the cassette where all the magic happens. In our first two products, it is very simple in the sense that we are running direct to PCR assays. So for our SARS product and for our new respiratory panel test, we simply load the we simply load the sample into the sample input, pop on the cap, and then put it into the device. Very simple, and I'll go through the workflow in a little bit. But what happens within the cassette is the sample is then lysed. It is then pushed through to the onboard dried reagents that are lyophilized in the cassette, rehydrates them, and then moves to the shuttle flow portion of the cassette. By moving the sample backwards and forwards between two different temperatures, 94 for the denaturation and the elongation temperature as well, we get this thermal cycling required for PCR. And this is what allows us to do PCR very, very rapidly in around about 7 to 9 minutes. In fact, we can go faster if we want, but for really good thermal and fluidic control, we run it around 7 to 9 minutes. And at the top of the device, you can see a long, thick channel, and this is the optics window where we're able to observe 6 channels of fluorescence so that we can multiplex within that channel. So very, very simple. In future assays, we are including onboard extraction with onboard wet reagents for the extraction, as well as a 225 spot microarray as well for really high multiplexing. That's just a little view into the future, so I won't dwell on that. We want to really focus on our respiratory panel for now. So, in summary of the device, we are very quick. We've got a very short turnaround time, around about 34 minutes. It's very, very simple to use. And for our respiratory panel, we are testing for flu A, flu B, RSV-AB, and SARS-CoV-2, all in one 34-minute platform. It is portable and with results that you can certainly trust. We always take quality very serious and have built in good quality controls both on the device and provide control material as well. So when we're thinking about positioning the technology and how easy it is to use, we look at centralized lab testing that has a turnaround time of anywhere between 4 hours and several days. And it's quite complex in terms of having to batch samples together, run the extractions, plate up all of the 96 well plates, and then get them into the PCR. And then you've got some complexity in terms of the interpretation of the results as well. So it's high complex, slow turnaround times. Other point of care systems that we look in the marketplace now, as I said, they're not at the true point of need. They are run in laboratories as stat tests. You can see them with a moderate complexity. They've integrated the extraction, amplification, and the detection, but they do require a skilled operator to run them. And of course, their turnaround time, because they are running labs and the way in which they're run, can take several hours. We're really looking at changing this paradigm by moving molecular testing to the point of need and making it easily and accessible to people to run it. In fact, we think that our workflow is as simple as a lateral flow test, and I'll explain that further. How we take the sample is simple. We've validated on a nasal mid turbinate NMT samples. As you can see, we take the swab sample, we then put it into the buffer. We invert that 5 times and then simply load it onto the cassette and put the cap on. We then put the cassette into the device, input some patient details, or have the QPOC read the barcode, which will then input the patient details that way, and then press go. And in 30-35 minutes, depending on the assay, for our respiratory panel, we're looking around about 34 minutes, and then we will get a simple result at the end of it. And we'll have the diseases listed, flu A, flu B, RSV-AB, and SARS-CoV-2, and either a positive or negative associated there. There is an option to go in to see the curves as well on these devices. So, as you've seen from the other speakers, we're getting very good clinical performance. When we've amalgamated all of our NMT data, we are able to report out that our sensitivity and specificity figures are extremely attractive for a very rapid point of need device. And this is driven mainly by the limit of detection, as you can see listed here from our analytical studies. So really does position QPOC as probably the best point of need molecular device on the market. And so why have we put this test together? Why do we feel it's important? Well, we've been monitoring the Southern Hemisphere's flu outbreaks and RSV outbreaks now for a number of years. And we've started now to see the flu rebound that we've heard so much about over the past couple of years in Australia. And data also is demonstrating that it's moving unusually fast in places like California in the Northern Hemisphere during the summer, which does suggest that there is a flu rebound on its way. So it is very important that we have a device that allows us to identify patients, first of all, and then triage them and segment patients. We certainly understand that co-infections could present an added burden to our healthcare systems. And by using this device, we hope that we'll be able to avoid a catastrophe as we saw at the beginning of the flu pandemic, the SARS-CoV-2 pandemic. And that is my last slide. I'm looking forward to taking any questions.
Thank you very much to our 4 expert speakers for what was a very interesting presentation. It is now time for our question and answer session. There is still time to send in questions for our speakers if you do have those. But I will kick us off today with the first question, which I think is for you, Dr. Jordi Villa, which is, do you expect a respiratory panel to be needed versus a COVID-only test? And what would the advantages of a panel be?
Well, can you hear me?
Yes, perfectly.
Okay, thanks a lot. Yeah, nice question, but difficult to answer because I don't know exactly what will happen in the next autumn or winter time. I mean, yeah, of course, is the problem is that symptomatology of the respiratory tract infections caused by these viruses is difficult is very similar. So we need a test to differentiate if the infection is caused by either SARS-CoV-2 or VRS or influenza, and if all these viruses are circulating on the same more or less level or prevalence, of course that we will need to apply this multiplex assay. Otherwise, if the situation or the scenario is that 2 of them are most prevalent, so again we can use the panel. But if only COVID is the most prevalent, influenza and VRS it's not prevalent, it's not detected. So then perhaps we need to use only SARS-CoV-2 detection. So it depends of the circulation of the virus, I will say.
Fantastic, thank you very much. The next question here I have is, COVID has clearly had a major impact on the use of point-of-need testing over the last couple of years. Do you think that there are other disease areas where we'll see increased use of point-of-need testing? And I think that one is for you, Professor Curtin. Are you on the line, Professor Curtin? Okay, we'll move on to the next question. Jordi, this one's for you actually. Where do you see the use for point of need testing versus central lab?
Well, as I said in my presentation, I mean the main application of this kind of size is the emergency department, and not only for the managing of the better managing of the patient attending the emergency department, but also to reduce the waiting list or the waiting time. Sorry, and I think that in this sense that will be a much better organization of the department. In addition, of course, we can use this size for intensive care unit patients that have this kind of symptomatology, and you need to differentiate what exactly is the cause of the infection, of the respiratory tract infection. Also for the urgent surgical intervention that we need to protect the surgeons of the potential infection carried by this patient that needs to be intervened. And also for the healthcare workers is important as well. As you know, we are shortage of personnel in the hospitals, and to have a rapid result in some way can also help in reincorporating the health worker to work one day earlier. So in this sense, to have this rapid test could be also a good implication in this really bad scenario, which is the shortage of personnel. At least in my hospital and in Spain, I don't know in UK, but this is an important problem in Spain.
Thank you very much. And the next question I have here, this one is directed to Jonathan, which is, can you talk a little bit about the assay targets for COVID?
Yeah, sure. So we have taken a number of the different genomes that are available in GSAD for the SARS-CoV-2 virus, and looked for a number of conserved sites within that, so within the S gene, the N gene, and the ORF1A, and have continuously tracked the new genomes being dumped into GSAD continuously to make sure that we are free from any mutations. And to date, our strategy is ensured that none of our sites that we have targeted have received any mutations, which is quite incredible. But by having multiple targets for each of our target pathogens, including flu A, flu B, and RSV-AB, means that we are avoiding that possibility of the assay not working due to mutations, simply through redundancy. So that's a very important point, that whilst it is on paper a four-plex assay, there are multiple targets per channel. So it's more than just a four-plex assay.
Fantastic, thank you very much. I'm just going to check, have we now got Kirtan on the line?
Yes, I am here, thank you.
Fabulous. So I've got a question here for you, which is, COVID has clearly had a major impact on the use of point-of-need testing over the last couple of years. Do you think that there are other disease areas where we'll see an increased use of point-of-need testing?
Yes, I think we definitely will. From a sort of broad perspective, most diagnoses or clinical presentations that are syndromic in nature, for example, sexually transmitted diseases, meningitic syndromes, respiratory being the typical one, acute respiratory presentations. Those are the ones where I believe we're going to need to, or we're going to see the need for, multiplexed approaches and looking at different pathogens and establishing a differential diagnosis where there's a syndromic presentation. And in our setting, as an archetypal example, besides the viruses, of course, pneumococcus is not uncommon, and also acute tuberculosis in our setting is a very important pathogen, just as an exemplar. But I think this is going to become more and more important, and also, we might see future pandemics and new types of respiratory infections that will emerge. And so I think this will become increasingly important. Thank you.
Thank you very much. And next I have an attendee question that asks, what internal controls are present to confirm a successful PCR run? Don't know who wants to jump in and take that one.
Yeah, I'll jump in on that one. Yeah, that's a great question. So we use a sample control for RNase P, and so that's already built into the assay.
Fantastic, thank you. And another question here I have is, how does this device compare to the ID Now?
Well, yeah, I'm happy to take this one as well. So having used both the ID Now and our QPOC device, they are very similar in the sense that they are small, relatively portable molecular devices. Our QPOC device uses bog standard PCR, whereas the ID Now uses an isothermal reaction. But I think the major differences are that the QPOC can multiplex. Right now, we can do 6-plex. By the end of the year, we'll probably be up to about 70-plex, that's 70. So if we wanted to do a triage test for respiratory pathogens looking at RSV, flu A, flu B, and SARS-CoV-2 on the ID Now, you'll have to do each test one after the other. Whereas with the QPOC, we'll be able to run that all in one. We've not yet done a head-to-head with the ID Now, but it's certainly something we probably would like to look at. I can't really comment on the relative clinical performance of the two devices put head-to-head at this stage. But one of the other important features I find as a former pathologist is the ID Now will require you to put the swab into the device and leave it there. And so there is no residual sample should there be an error with the test or you want to do reflex testing. And so when I'm thinking about doing a respiratory panel on the ID Now, one would probably have to take 3 or 4 swabs to do what we can do with one swab. So there are pluses and minuses with all these technologies, but I think from that perspective, and from the multiplexing perspective, I think the QPOC has the edge. But I would say that, and clearly I'm rather biased on that. But I think when you do take an objective view of it, QPOC is superior.
Fantastic. Thank you very much, Jonathan. That is all that we have time for today, unfortunately. But I would like to say thank you once again to Jonathan O'Halloran from Quantum DX for joining us, and also thank you to Professor Curtin Dieder, Dr. Jordi Villa, and Professor Sanjeev Krishna for joining us and for the presentation. And thank you to everyone who's joined us online today. And for sending in those fantastic questions. I hope you found this to be a really worthwhile session. If we didn't have time to answer your question today, we will follow up with these after today's event. And if you have any other questions, do feel free to email me at editor@selectscience.net, and I can follow up with your questions for our speakers. You can also download a certificate of attendance for today's session, and you can find that in the resources tab to the left of your screen now. And if you'd like to listen again to today's webinar, or maybe invite a friend to listen, it will be available to watch on demand in just a few days' time. So for now, goodbye, and thank you once again for joining us.